erectile dysfunction is the canary in the coal mine of cardiovascular disease.
Every single one was from trazodone. Everyone. So if you're on trazodone, you might want to reevaluate, aka the Wang watch, but it's called the FirmTech tech ring. And basically it's a smart watch for your wiener. Full disclosure, I take 5 milligrams of Xiala every day.
Does testosterone cause prostate cancer?
Of course it does. I'm just kidding. No, it doesn't cause prostate cancer. Stigmas die hard, I'll put it that way. I am the first non-physician in the United States to perform intravesical Botox for overactive bladder.
Whoa.
So, that's my claim to fame.
I like it. That's awesome. That's a pretty cool claim to fame. Well, thanks for tuning back in. Today we have Josh Dole. He has a clinic in Maryland and has honestly kind of been my phone a friend prostate guy over the last several years. We've been in a couple groups together, and anytime I have a prostate question and I send it in, I always hoped, even before we chatted, I always hoped that he would be the one to chime in and see it, because he was always very thorough and his answers were awesome and just what I needed for it. So he was in urology first, but now has a hormone optimization clinic in Maryland and several telehealth states. But I'm going to let him kind of take over what states they offer and his background and how he's at to where he's got today. So thanks for joining, Josh.
Yeah, thanks for having me, Mason. It's been probably a long time coming. You know, we've kind of had you on our show a couple times.
That's what I was going to say. Right? Yeah, co-host of the TRT Dad podcast.
Yeah, so 70 episodes and counting, of which you guys have been a part of a couple. We greatly appreciate that, and we look forward to many more there. So, yeah, I'm Joshua Dahl. I'm the medical director, if you want to call it that, lead clinical provider of Venous Health Optimization in Hagerstown, Maryland. We do telehealth. We also do women's health as well. I have a women's health practitioner, Dina Hull, who works for me. Yes, it's Hull and Dahl. We are boring boats.
That's awesome.
Yeah. So, but she does a great job, does the women. Her states don't currently match parity of mine. So while I treat basically everywhere around Maryland, so we have Maryland, Pennsylvania, Virginia, West Virginia, Delaware, New Jersey, New York, Florida, Nevada, and I just added Michigan and Minnesota. And we have more states coming soon because I just had a new hire. He starts in June. His name is Richie. He will, thank you. And we will be expanding into many, many, many more states. Probably by the time he's done with his training, my guesstimate's probably end of September, early October. But by the time his schedule starts, those states will already be ready because we're going to obtain them during the training phase. So looking forward to that. And then Dana does pretty much the 5 states around us. So Maryland, Pennsylvania, Virginia, West Virginia, Delaware. She does New York and Florida as well. So
nice. You are killing it.
Yeah, we're doing pretty good. You know, the podcast has been a great outreach for us. And honestly, that wasn't even my intent of why we did it. But it's just been that. And I love doing it. It's probably the only type of social media I like is this type of stuff here.
Yeah.
Just because the other stuff's a little too, it's hard. People don't go to short form, social media for education. They go there for entertainment. And it's really hard to make this stuff entertaining. It's so you can make.
But man, you and Matt, the TRT dad, man, y'all just jive so well. It's just y'all. It is so. I listen to it all the time.
We appreciate that,
and y'all do great.
It's honestly the way we kind of dialogue is just like we're at the bar. It's kind of great, and I like it like that. It's like just two guys, regular guys talking. And that's kind of how it should be. And that's kind of when we put together the podcast, that was sort of the cadence that we wanted to follow. And I think it works pretty well. And it's been very, very responsive for people. They really enjoy it. So we've gotten a lot of feedback and we're going to continue. It does really well. So,
and we'll have a link to it in the description and everything. So people can go and follow.
So my background, obviously I've been in my health clinic for 2 years. I've actually been in healthcare for 23 years. Yeah, I'm showing my age. I am 42 as of August this year. So
nice.
I started as an assistant. Actually started in the kitchen at a nursing home and then kind of worked my way out from there. But became a nurse in 2007, and from 2007 till 2018. I was a nurse in the hospital. I have a background in emergency room and PACU. So 4 years in the ER, 7 years in PACU. And then I became an MP in 2018 after graduating from Penn State. So I went to Penn State to be an NP strictly to take a job in urology. Like there was no like, oh, hey, I want to do this. Oh, hey, I want to do this. It was like, I'm literally going to school to do this job.
That's awesome.
So I had the job before I even graduated. So it was pretty cool. And I started, and the doctors that I worked with were excellent. They gave me a lot of, I don't know if you want to call it training per se, but they were good. Yeah, we'll call it training. A couple of their versions of training was more, you'll figure it out. But
Right. Yeah.
right. But
I kind of had some hard training too, but man, it helped me on the back end.
I would say so too, right? It's like that tough love,
Yeah.
But they were always there, and they weren't going to let me fail. So greatly appreciate that. I worked in urology for 6 years, was doing all sorts of procedures. Matter of fact, I am the first non-physician in the United States to perform intravesical Botox for overactive bladder.
Whoa.
So that's my claim to fame.
I like it. That's awesome. That's
Yeah.
a pretty cool claim to fame for sure.
Yep, guy in the whole U.S. doing that procedure. So I really like to do procedures. We do a lot of cystoscopes, which is we take the scope, we stick it up through the penis or through the urethra in a female, look inside the bladder. Did some bladder cancer surveillance, gross hematuria workups, whole 9 yards. I loved it. Just minor surgical procedures in the office. The only thing I didn't do was vasectomies, only because I just didn't want the liability for that. So I was like, I'll let somebody that does a lot more than what I'll do of these. I could have learned them. I didn't. I mean, I probably could do one, but I just led it to the docs. So they were good for that. So, but yeah, I spent it in obviously we did low testosterone incorrectly in urology.
Okay, that's a good point. Yeah.
Yeah, incorrectly. But at the time, that's what you think. It's what you're taught. That's all you know. You're kind of trying to follow AUA guidelines. I think we talked about AUA guidelines in one of our podcasts within the past 10 episodes, I want to say. But
even up to date, I mean, I haven't checked up to date in a while, but last time I checked, it still had the 200 every 2 weeks. And it's like, man, this is not changed. It's definitely not up to date. I don't know how they're keeping up with that, but
no.
Yeah, the guidelines and stuff just aren't.
Well, even values and understanding what the values mean. I mean, none of that stuff's discussed. Nobody knows that. Everybody, it was like you gotta look at a total. Everything was total this and total that and total. And if it's in the total, if it's in the range, you're good. I mean, none of it made any sense. I mean, put guys on androgen, which is terrible, and they come back and their testosterone be lower than when we started. And I'm going, what's the point? Like, what are we doing here? And that's where I really started to scratch my head. I'm like, how is this working when, we have them apply this every day and we literally get a lab and their testosterone level is even worse than when they started. Obviously, I know the difference between that now, but at the time, you're kind of like wondering what the heck. And, as far as getting support from somebody, they don't know either. So you're kind of just in a ship without a sail, essentially. You're just kind of out in the middle of the ocean, just sort of floating. But did some of that, and I finally just kind of got fed up with it. Loved the job, don't get me wrong. Loved the work, love urology. We got bought out by a larger health organization. Unfortunately, my value was not worth it to them. So I said, see you later, and went out and did my own thing. And it was the best decision ever because I get to practice healthcare the way I think it should be done. And that's certainly putting the patient first in every aspect and getting them the care that they need and really providing that. And we have a lot of happy patients in our clinic for sure. And just we want to give that like kind of one-on-one care. Each practitioner is limited to how many patients they can see. So it's never, when I was in urology, I had 4,500 patients. That was my panel.
That is wild.
Yeah, the max we have at my clinic is 400 per provider. So that's it. I'll cap at that. No, you'll not see anybody more than that. And that's just because I feel everybody gets a 1 hour follow-up every time. I just feel that's the way to do. And I mean, part of good care is knowing your patient and knowing not just their health history, but also like their personal history, what they're into, knowing them as a person and really working with them in every aspect of their life. How's your dad doing? And how are the kids? What type of activities are you into? Did you guys get to that ball game that you wanted to do? People like that. They want to be treated like a person, and we want to treat them like a person too. from that aspect, but at the same time, we want to work kind of on the back end to help them achieve that. So really is, I think, a good philosophy. And I went into it with how I would treat patients exactly how I would want to be treated. So,
Yeah,
but
that's kind of how I used to tell people is like, look, because I'm kind of the same. We give you an hour up front initially at least, and typically follow-ups, 30, 45 minutes for the most part. Again, just get them to know them. And I'll tell them like, look, I'm the same person, but if you had seen me at urgent care and I gave you about 90 seconds of chatting, looking in your ears, your mouth, your throat, and going over your test results, and then
right.
I got to go to the next four that are already roomed and try and get them going. And so that's kind of the same mantra. Is like, okay, if I'm gonna do this, I have to do a model to where I can focus on the patient and they can do it. And it's like it's just a different model. It's not the insurance model, and it
Right.
allows us to be a point of contact, be responsive, long follow-ups, be super thorough. And so
Oh,
we've
it's
kind of
it's
done the
nice
same.
when patients finally realize when they spend their money on their healthcare, they realize the choice that they actually have and the agency that actually provides them versus going through insurance, where the insurance dictates what you can do, but when you pay for your care, you can get exactly what you want. I hope that people kind of wisen up to this. It's kind of a shame because insurance keeps getting more expensive, but the care quality keeps getting less and less. So there has to be something that gives here at some point. So we'll see what
Yeah.
happens.
Yep. And so really on this podcast, it's going to be just penis and prostate focused. I want to kind of deep dive into erectile dysfunction, the prostate, and kind of how testosterone interplays with all of that. But that's going to kind of be the main ticket today. The first thing I want to kind of start with erectile dysfunction, and
Sure.
it's more complex than just here's testosterone, it's going to fix everything. And erectile dysfunction is the canary in the coal mine of, cardiovascular disease. It's a marker of your, just vessel health. In vascular erectile dysfunction, there are some other stuff, but
Sure.
it is somewhat of a more warning light for the rest of the body. So I want to I'll kind of stop talking, and I just kind of want to hear your approach to erectile dysfunction
Sure.
and what you're looking for.
Yeah. See, if I get a guy that comes in, and I guess what we could talk about is if I was in urology, the only really thing I could do for erectile dysfunction was basically phosphodiesterase inhibitors, so Viagra or Cialis, or potentially Trimix. We'll get to that later, but I don't want to put cart for the horse. But that was kind of what I was limited to. Now, we did offer procedures in terms of like we could do a penile prosthesis, but those were typically reserved for like pretty extreme cases, like prostate removed, neurovascular bundles removed, can't get an erection, period, because there's literally no stimulus down there to create
Hmm.
vascular flow into the penis. So that was what those were for. But outside of that, I mean, these are our options. And at the clinic I'm at now, we have a lot more options than that. And we'll certainly go over those. And they actually work out very, very, very well. They're actually incredibly effective tools to kind of help get that back on board. So ED, you get a guy that comes in, typical, we'll say, I don't know, 50s, right? Erections aren't the same, have a hard time. And we get all different types of stories. I can maintain, or I can obtain, but I can't maintain. That's one. I can't get one at all. If I do get one, maybe it's kind of weak, the quality's poor. So, I would always assess, like, okay, give me the scale of as good as your erection can be on a scale of 1 to 10. How would you rate it? 10 being the best, 1 being the worst. And we get kind of stuff all over the place, all 4, 5, and if we trialed like a PDE5I, come back in and say, oh, okay, it's a 6 or 7. Is it serviceable? Okay. Obviously the easiest way there, but also distinguishing what type of erectile dysfunction that they had. And there's 4 major types of erectile dysfunction. We have vascular ED, which is basically vessel dysfunction. That's caused from diabetes, high blood pressure, smoking, anything that's going to damage the vessels. You have hormonal ED, which is obviously directed towards like low testosterone. It could be even due to high prolactin. I've actually seen that before. And generally, high prolactin doesn't necessarily impact, at least in younger men, doesn't impact the function of the erection, but it does impact the sensitivity, and they can't ejaculate.
All right.
So
Yeah.
we have neurogenic. They would get that with people with like neuropathy, MS, any type of neurodegenerative disease. extremely bad diabetes, that type of stuff. And then psychogenic obviously is, it didn't work once and it won't work again, and they just don't get out of their own way. So,
Yeah.
but it's a real deal. And that's the most common one with young men. Okay.
Yep.
I would say the most common vascular and hormonal, you could probably lump into one, in my opinion, only because like endothelial dysfunction is technically a low testosterone related issue because of not having estradiol to modulate nitric oxide. So we do lose that a little bit. So testosterone is a potent tool for kind of helping that. The only thing I would say is truly if it's like I smoked for 50 years and my vessels are like hard as cement and they don't dilate, then get a little crafty to fix that. It can be done, but definitely a little bit more challenging. So what do we do about it? Got several options. Obviously, the easiest option here, take some Viagra, take some Cialis. I don't use those two interchangeably. And then we have a couple other. We have Vardenafil is our third, which is Levitra. And I believe Staxin was like a fourth one that came in. But Staxin is, I'm pretty sure, Vardenafil as well. It was never used. Pretty much, I think it's supposed to be a pretty quick onset. But in my opinion, sildenafil and Tadalafil are pretty much the two major players. Sildenafil has a short half-life. Typical doses are going to be 50 to 100 milligrams orally. It is highly lipid-bound. What I mean by that is, so when we educate patients on this that use this drug, is if they had anything with fat in it and they ate, don't take it. It'll render it completely useless. So, and that can pose a challenge. If you're trying to take a pill before intercourse and let it kind of marinate for an hour so it gets into your bloodstream, and you ate, it's going to take longer than an hour to get in your bloodstream. So that really, and now you see sort of their variants of that. There's like Blue Chew that's out there, which I don't know if Blue Chew is absorbed orally or if it's more of like a buccal or what. I'm not sure. I don't know. It's just like chewable sildenafil and chewable Tadalafil. We actually offer a sublingual variant in our clinic.
Yeah, that's what I was going to say, yeah.
And that goes in through the lymphatic system. So no first pass liver metabolism. Doesn't matter if you ate, and you're really rocking and rolling in about 20 minutes. So we do like that. So sildenafil is more potent. It's going to be your front runner in terms of typically older men that have more severe ED. Okay. And we're going from mild to wild here. So this is obviously the easiest, most cost-effective thing. We're not really spending a ton of money yet. We're just throwing spaghetti at the wall and seeing if it sticks. And if it does, great. If it doesn't, okay. I do want to preface, prior to any of this, hormonally optimizing somebody is pretty much paramount. Because especially in the aging male, the lack of testosterone and the lack of nitric oxide in circulation and the lack of nocturnal tumescence, that's a really big key indicator for really determining overall penile health, is how many erections do we have at night. You should be having anywhere from 3 to 5 erections when you sleep. And if you go on testosterone, I actually have to have this discussion quite often, you may lose your morning erections, meaning you might not get them anymore. And the reason being is because we get morning erections because LH is surging early in the morning, typically between like 6 and 11 a.m. On somebody with a fairly normal circadian rhythm. And that surge, that rise is what causes that morning erection, okay? It's also, you're kind of coming out of sleep and it's probably that last nocturnal erection of the day and you're just kind of like getting it at that time. When you go on testosterone, that process is no longer in play. Obviously, we get gonadotropin suppression. There's no more LH surge. It's suppressed. Your levels are high kind of fairly all the time. There is movement, but it's not movement from like a really low level to a really high level. It's usually from like a pretty good level to a lower good level. And because of that, we may not get that morning erection anymore because we're not in that cycle. But we should see improvement in erections when you sleep. And so that's a key indicator. And I actually have a device here. I think I brought this up a couple times. I think we talked about it in our podcast. I'll show it here. Hold on. It's stuck. There it is.
Yeah, I was going to bring it up if it didn't come up.
Yeah,
naturally.
here it is.
Yeah.
So we call it
awesome.
AKA the Wang watch, but it's called the FirmTech tech ring. And basically it's a smart watch for your wiener. And it, if it's there, it goes around and it just sort of sits there and you turn it on at Bluetooth to your phone. And you just wear it just like that when you're asleep. It don't have to be erect or anything. It sits there. And what it does is while you sleep, it measures how many, erection episodes you have when you sleep. It measures how long they are and how kind of firm it gets. So then not only do you get the amount, you get the length and you get the quality. So, and that's how we can really start to determine erectile health. So if you have somebody that has severe erectile dysfunction, that's a good indicator of really seeing progress as we, move some of these modalities. Okay. So back on, sildenafil is most potent. It's going to last roughly 4 hours. It's more of like a mountain peak, right? Real quick to the top, real quick fall off. Tadalafil does not have the peak. It's more of a plateau. It's up to a point, but then it's got a 36-hour half-life. Pretty long, 24 to 36 hours. And so you can take Tadalafil much earlier in the day, just kind of let it get in your system. And then, their taglines for when the moment's right. And it can be used to that effect, but it's not as potent as sildenafil. So if you have somebody with more severe erectile dysfunction, Cialis or Tadalafil is not going to be as beneficial for that particular person. Full disclosure, I take 5 milligrams of Cialis every day.
Nice, yeah.
But I don't take it for obviously erectile issues. I take it for nitric oxide modulation and performance. So you can use a low dose Tadalafil daily. Remember, it has a 36-hour half-life, and we get better oxygenation to muscle. So workouts are better, pumps are better at the gym. If you can get more oxygen to the muscle, you can stress the muscle out a little bit more and use that aerobic metabolism. So like less lactic acid buildup, that type of stuff. So it gives you just a little bit of an edge in the gym for performance. Vascularity is improved on that. So, from an aesthetic standpoint, if you're looking to get the veins popping out and everything, it's a good add-on for that. So we have a lot of guys that use it in that capacity. So those are your two. Levitra obviously is a third. I have, or vardenafil. It's very comparable to sildenafil, but it's more expensive. So
yeah, it's typically just cost ineffective for the vast majority.
Yeah.
Yeah, we probably have 80%. And, some guys are somewhat hesitant at first. And I'm like, yeah, also it helps with urination.
Yes, it does.
It helps a lot. And so it's like, but it's like, okay, we get them on it and they're like, yeah, gym wise, it's good. Urination's good. Lowers blood pressure a little bit. It's not like I'm using it as an antihypertensive, but it is going to decrease it some. And again, all positives throughout the day. What about the guys who say, that's garbage. It just never worked for me?
Yeah, and so there is I can't remember the percentage. I want to say it's like 20 to 30% of men do not respond to phosphodiesterase inhibitors, meaning it just doesn't work for them. And this could be a combination of items. This could be, I just didn't take it correctly and I don't really understand how to take it correctly, or it could just didn't work, or they got a side effect, right? Headache is the number one side effect because it does increase nitric oxide retention. And that nitric oxide causes vasodilation, and the dilation in the brain is what's going to give you a headache, okay? So a lot of guys get headaches when they take this medication, and they just don't like how they feel with that, so they don't want to take it. I always told them to take it with a Coke.
Nice, get the caffeine in it.
Yeah,
as well.
exactly. Yeah. Take it with, Coke or Diet Coke, and see what happens. And, surprisingly, it would help. But
nice, yeah.
Yeah, so there is a subset of men that just do not respond to this medication or it doesn't work favorably for them. So we have to look at alternative options. And this is when we start getting into kind of the real sort of nitty-gritty stuff. And this is going to pretty much, like I said, we're going from mild to wild. So the next item in line would be probably bimix or trimix or quad mix. We call this intracorporal injection, and basically what it is a mixture, either 2, 3, or 4 mixture of basically vasodilators to the penis that's locally injected in a small insulin syringe into the corporal body. So one of the corporal tubes that go down the shaft of the penis, you're going to inject it into there. And what that will do is bring blood in and basically elicit an erection with zero stimulation. So you put it in, and 10 minutes later, we're, tent is pitched, okay? And it worked quite well. So we would use Trimix, and so it's alprostadil, phentolamine, and papaverine. Okay. And then quad mix adds atropine to the mix. So, and you can get them in various different preparations of, ratios of what they are. I kind of have a standard one. I don't remember what it is off the top of my head. I think it's 20, 10, 30, but I can't remember which one's which. It's been a while. We have it at our office.
Yeah.
And yeah, they can inject that up to 2 to 3 times a week for intercourse. It will elicit an erection.
And you don't mix with Tadalafil, right?
Correct. You do not take this with the phosphodiesterase inhibitor. This is a solo monotherapy, just like how a phosphodiesterase inhibitor would be kind of like a solo monotherapy if we're just using it in that capacity. So you give the shot, you wait about 10 minutes and, off you go. It will stay erect even after ejaculation. So you have to educate your patient on that even after you give this stuff and, a guy ejaculates, it couldn't stay hard. And then also the risk of priapism is a real thing with this, which is priapisms that, you hear it from the phosphodiesterase commercials. If you have an erection lasting longer than 4 hours, you need to seek medical attention. Do you know how many priapisms I've seen from a phosphodiesterase? 0. I've had 1 from Trimix and 5. So I've seen a grand total of 6 in my 6 years, average 1 a year.
Can I guess what your 5 is?
Sure. Go ahead.
Trazodone.
Yep. 100%.
Yeah, that's what we called it in the ER was trazodone.
Every single one was from trazodone. Every one. So if you're on trazodone, you might want to reevaluate. And you're a dude, you might want to reevaluate actually using it because it can happen at any time. You could take it for years, and then all of a sudden, boom, bam, and it happens.
Yeah.
And then you have to come into the ER, and we have to put phenylephrine injected into the penis to see if we can get down, assuming that you came in a 4-hour window, and some people don't, and then it gets extremely painful, and then we have to do a shunt, and you do not want a shunt. So,
in the operating room, or are you talking about the irrigation?
No, so basically we would have to do a shunting procedure. We would do a penile block right there at the bedside, and then we would take a large 18 gauge syringe and right in the tip down into one of the corporal things, and you'd have to squeeze the blood out as much as you could.
Yeah.
And you would have one in each side, one in each corporal body. So you would do one on one side and one on the other. And you're basically just trying to decompress,
Right.
And we would do it that way. There's another one where you could actually just take an 11 blade and go in and just cut straight in and kind of make a big puncture wound that way. Yeah, and then if that didn't work, you're basically going in and you're probably cutting in and trying to remove clot tissue from the inside. But that's a real thing because if that's not treated, it could lead to permanent erectile issues.
Right.
So rare, but can happen. Assault once from Trimix, but it's generally pretty safe. I think the guy that ended up having it probably was lying about his erectile dysfunction because they use a lot of Trimix in porn. And
okay,
so it's heavily used in the adult industry, and people get fixated and they'll this didn't work or this didn't work, and in reality it was fine, but we're taking these people's words for it, and then they're getting what they want because they're like, oh yeah, I'm gonna be like John Holmes here, and I don't think he's probably relevant nowadays, but some of the older people might laugh at that.
Yeah, I don't know who that is, to be honest.
It's like John. He's like a porn star from the 70s.
Nice. I like it. I have one guy who likes it from a purely optimization standpoint. He doesn't need much, and one vial lasts him forever.
Yeah.
And he's just like, if I want to have a wild weekend, I know what it does, and I do well with it, and we'll rock and roll with it. I am for the most part using it on the more severe guys. Yeah. But I will say it takes some convincing a one to want to inject your penis prior,
100%.
But then we've had good success whenever we've had to bring it on. There's just been a one that I think was just too severe that I'm just getting kind of lackluster results on that we're still kind of working on, and we may just need to increase the concentration overall, but for the most part we've had good success with it overall. Yeah, and I kind of like you said, it can stay erect after
Hmm.
ejaculation. I mean, I haven't had to use it for this, but I know it's somewhat in the arsenal for like premature ejaculation. If you just can't last any time at all, it would stay erect so you could go round two quicker. Have you ever used it like that or anything?
Generally, I have, yeah, I have, but I would say long-term phosphodiesterase inhibitor use can also cause a little bit of desensitization as well. So if you get somebody that's on it for a while, sometimes,
Yeah, that's my first line
yeah,
for sure.
yeah. But that's kind of like, but you can absolutely use it in that case because then it's just like, okay, well, you know, cat's out of the bag, but at least I can continue to go a little bit and,
Yeah.
maybe get my partner to the finish line too.
Yeah. I do want to touch on, a lot of erectile dysfunction is a mix of all of this,
Correct.
especially like, a say a medically complex patient that is diabetic, they're going to have some vascular, they're going to have some neurological, they're going to have some hormonal. And so it's a mix, but I'll say psychogenic erectile dysfunction and problems is huge and not something guys pick up on themselves
Right.
that very often. And so like I'll use Tadalafil or something in a young guy to get their confidence back, and then they feel better about it and then they're more confident and then
For
so they're
sure.
not as negative. And like I've had it where it's like all it takes is a partner to make an off comment and it's in their head
Yep.
forever. And so sex therapy is something that helps, pelvic floor, physical therapy, that kind of stuff. Do you utilize those at all or have you had any experience with them?
I've not done any like psychotherapy for that. Actually, I mean I personally haven't. I did
Right,
refer
right, right.
probably about two people for that because they just wouldn't get out of their own way. And
Hmm.
then pelvic floor physical therapy for erectile issues, no. I've used that more for like CPPS or void or like lower urinary tract symptoms
Yeah.
or overactive bladder issues in females, that type of stuff, but never for erectile dysfunction for men. We never went down like that road for that particular thing. But yes, have used those therapies just in different capacities.
Yeah. And then we've talked about it in the past, y'all kind of offer the same kind of the next step. We offer, shockwave treatment, P shocks, that kind of stuff. What is
Sure.
your experience with these and when do you bring them in on a guy?
Yeah, so I mean, they can theoretically be brought in at any time. I do have a criteria before we get in any procedure, and that's the individual has to have their testosterone corrected. Because
Mm.
if I don't correct that first, and it's an older, or even just 40s, 50s year olds guy, and he's hypogonadal, this is just sort of a temporary banding, not a permanent fix. And I don't want to even really technically call it a permanent fix because you still have to have some of this done periodically. It's like laser hair removal, right? It works, but you got to kind of do it periodically to kind of keep up to it. That's kind of how this stuff is too. So, but yeah, we have shockwave therapy. I actually think we have the same units. So we have the
Yeah.
Stores
Yeah.
Master Pulse Ultra Plus radial, which will penetrate up to 60 millimeters if you use the brass head. But I typically use the 40 millimeter penetrating head, which is, I think, the gray one. And what that
Hmm.
does is it's everybody thinks like shockwave. They're like, oh, you're an electrocute me. I'm like, it's not TENS unit.
Right.
Like it
Yeah.
doesn't electrocute you. So I like to explain it to them, and I have them hold the other arm, and I put the gun on it, and they're like, oh, that was it. I'm like, well, we're gonna turn it up. you
Yeah.
know.
Same.
And I said it's like a jackhammer, essentially. It's a jackhammer
Hmm.
that smacks you 15 times a second, and we're gonna turn the bars of pressure up. It should be uncomfortable but not painful, and we do that on the penis. So we actually do basically kind of the right groin for 500 pulses, the left groin for 500 pulses. We do down both sides of the penis, both the right and the left shaft, all the way from basically the base to the glands. 500 shocks there. And then we do the pudendal nerve underneath. So I kind of have them get up and put their legs up, and we kind of get underneath there, and we do 1,000 to each pudendal nerve that kind of
Really?
comes in.
Okay.
Yep. So they get
Nice.
a total of 4,000 shocks per session, and a full shockwave session is going to be 6 of those. So
Right.
it only takes about 5 to 10 minutes per session, so they're fairly short. They're not very painful. No NSAIDs or ice for 24 to 48 hours. following the procedure. We only offer these in our clinic on Mondays and Thursdays for that.
Okay.
And or you can do one Thursday and come back Monday, or you can do it Monday, Thursday, but we can't do them any other time because we need that time frame in between because of how Shockwave works. And what it's doing is it's basically causing micro trauma to the area, and then it's relying on your body to send its signals there to basically repair the area. And we want that inflammatory response. That's really what we're kind of after with the Shockwave therapy. We're kind of disrupting everything there. And not only does it help with creation of new blood vessels and nerve stimulation, it also helps with Peyronie's disease, which I know we were going to kind of chat about too. So that's that plaque formation that causes curvature. We can't basically take somebody that's curved and make them straight again, but we can straighten them out and get them straighter than what they were. Okay. All without really loss in overall length. Because if you have to have a plication, which is an actual surgery where they deglove everything and they go and they basically kind of cut out some of the plaque, but then they suture it on the other side, you lose length in that. And some guys are like, I don't have a lot to work with, and you're going to make me shorter, and they're not too keen on that. But it really just depends. I mean, I've seen fish hooks before. So, I mean, and that's something where I would say Shockwave plus a P-shot would certainly be warranted, and maybe we can get it to be like that instead of a fish hook versus having a plication, which will get you pretty straight, but it's going to be shorter. Okay. But that's Shockwave kind of in a nutshell. We can also use Shockwave for musculoskeletal issues, which we do use it in our clinic for that. A little bit different protocol to follow that. You can change the heads around depending on the area that we're using. I know this isn't the topic of discussion, so I don't want to derail that, but that's
and it works well. We use it a ton for musculoskeletal stuff.
It does.
Get good results.
It works. So. It works awesome for that stuff. So, but yeah, that's Shockwave kind of in a nutshell to kind of help with ED. It works really, really well. But again, testosterone has to be fixed first before we kind of bring this on board, or we're just sort of only getting half of what we could potentially get out. I like to pair this therapy with kind of the next one, and I'm pretty sure you're going to bring it up, which was the P-shot, which we do that as well. And the P-shot is basically, it's a procedure where we draw your blood, 20 cc's of it. We spin it down, and we take the plasma that's available to us, generally about half of that, so about 10 cc's, and we basically inject it back into the penis. And that has all like your stem cells and everything. And that kind of loosely does almost the same thing as what Shockwave does. It creates angioneogenesis, it creates nerve regenesis, that type of thing. And we put that in there. You also get immediate girth improvement, usually after the first shot. And if you have lost length from atrophy, you can even gain some length back in overall. So we can't obviously add something that's not there. There's this misconception that everybody wants to be as big as possible, but you're only going to be as big as you can be, unfortunately. So it's what you get. That's what you get. I just got to work with it. But certainly the porn industry likes to make light of everybody. The bigger is better, and I think most women would probably not prefer anything that large. So they want something more average.
We after either of these procedures, we use a penis pump.
Okay, we do
get
too.
them to pull everything through, and that kind of lets them know their max potential. Because it kind of restretches, refills everything. And one, it pulls all those stem cells, growth factors, healing factors throughout the entire corpus cavernosum, the glands, making sure it's all distributed throughout.
Right.
And then it's also like daily exercise for the penis, and it's focused to that area that really helps. One of the things I kind of stress with people too is erectile dysfunction treatment, they're not quite like I don't really measure our success in like 1 to 2 weeks. I'm really looking 3, 4, 5 months of treatment. And so I kind of have a setup, where whenever we're doing it, I put them on daily Tadalafil. I like some nitric oxide precursors, whether it's beetroot powder, citrulline, whatever, just to help. This is the term that you fill the sink with nitric oxide so that it stays around longer.
Yep.
And then use the pump every day. And then at minimum, go for a 30 to 40-minute walk. Just get your heart pumping again. Anything we can do to improve your heart health is going to improve your penis, your erectile health. And so I try and pair it for multiple different ways.
Yeah.
But Do y'all use the pumps as well?
Oh yeah,
And
100%.
what?
That is a mandatory. That is a mandatory requirement. I haven't yet had anybody just do Shockwave without the P shot. So it's not like when
Okay.
we do Shockwave, I don't have them pump after that. We don't start the pumping until P shot 1. But the way we do ours is a little different. We do 4 Shockwave sessions first, then a P shot, then 2 Shockwaves after.
I like that.
So,
I like the shockwaves first. That's what I've been doing because I feel like it's going to help somewhat, go and break up plaques, from a
exactly.
mechanical advantage, and then hopefully help get that blood flow pulled through better. And then the
Yep.
P shot is just straight stem cells, growth factors, healing factors, and just going to amplify the
Yep.
effects.
And then I like to rattle it around again after, the next 2 times and they have
Yeah.
another 2 Shockwave sessions. So that's been working really, really, really well. I like how we have that structured. So
How long do you wait to go back to the shockwave? Is that like 1 week, 2 weeks, or?
so how it works typically is, remember, we only do Mondays and Thursdays. So they'll do Monday, Thursday,
Mhm.
Monday, Thursday. They'll generally come in either Monday or Tuesday, and then they come in Thursday, literally like 2 days afterwards. And we're doing
Okay,
their next Shockwave, and then the last one's on Monday, and then they're done.
gotcha.
And then it's usually nobody ever gets 1 P shot. Everybody typically, unless it's like a maintenance. But if you're doing it like your initial go around, we're doing minimum of 2, sometimes 3, depending on the severity. And we'll do that 8 to 12 weeks later after that for the
Yeah,
second
and
one.
it's kind of one is going to get, probably 60 to 70% improvement, but getting that second one gets it up. What are you seeing? 85,
Oh
90%?
yeah, oh yeah. We're truly getting some pretty remarkable stuff. And the funny thing is when I was in urology, this stuff existed, but it was kind of like taboo, I guess you could say, because
Yeah.
it's never been accepted by like medical therapy. I'm pretty sure the AUA put out like a position statement on it, and this was on like the P shot and Shockwave, and they were like, "Listen, like we're not going to say that you should do it, but we're going to say that you should not do it." They were kind of just like, "We'll be Switzerland." And we'll just be neutral, and we're not gonna be for or against it. You can decide, But there's obviously evidence out there that's been done that shows that both of these therapies are effective. And I think
Yeah.
when you get a guy in desperation who's really just looking for good counsel on how to fix this problem, and he wants it fixed, and he's fixable, right? It's not so far gone that your diabetes is just thrashed to the hilt, and your A1C's been, Mrs. Butterworth for the past, 15 years. I can't fix that, right? That's, kind of too far gone essentially. But
Is that a penile prosthesis discussion at that
that
point?
that probably is going to be a penile prosthesis discussion at that point. And I'd have to send him somewhere for that. But if we still have some function and we just need to optimize, then yeah, 100%. And I remember the first shot I did, and then the 8 weeks later we did the next shot, and then we had our 3-month follow up after that, 12 weeks later, and and he's like, dude, this is amazing. Like it's so much better than what it was. So there's obviously a noticeable improvement in quality that these patients notice. So it's not just a fluke therapy; it 100% works. Now, if you have pretty good function already, and you're just like, I want to do it for enhancement purposes, like you can get a little bit of girth potentially. Probably not going to get any length because that's going to be more from atrophy, but you're not going to gain much out of it. It's truly for people that need it. And that's where it really shines. But I've had great success with both therapies when used together. So
Yeah, and they're both safe. Like P shot, you're
extremely
not going to really mess up much. I mean, as long as get somebody that knows what they're
right.
doing, and it's a big target as long as you're not going to the artery or nerve at 12 o'clock.
Or into the
Otherwise,
urethra. You don't want to do that
right?
either.
Yeah, yeah.
Your next thing you know, your plasma's coming out at the
Yeah,
meatus at the end.
yeah.
So
But for the most part, that's not going to happen with
no, if you got
normal
somebody that
things.
knows what
And
they're doing, you're totally fine. You can avoid the corpus spongiosum, which is the outside of the urethra there, and just hit the cavernosal body. But yeah, it's great therapy. We get questions like, can I come off of, Viagra or Cialis? You get a lot of guys that like, I don't want to take this because I don't know if they look at it as kind of like weak, right? Oh, I shouldn't need this. And listen, sometimes you might just need it, right? it's not bad to want to keep nitric oxide around. That's all it's really doing.
Yeah.
Unfortunately, the connotation of their head, the psychology of it is, well, I need this to get an erection. And it's like, we might have to use it, right? We might, your medical history might get us having to use it plus a procedure for you to just be serviceable. That's reality. Like, we have to live in reality, unfortunately. We can't, I'm not Jesus. I can't do miracles. I can come close, but I can't, there you go. So, but
I do want to touch real quick on just venous leak. I mean, a lot
sure.
of guys can get an erection and they have trouble maintaining it. Is that always the venous leak? Two things I help try and mitigate is one, apply a constriction device, a
Yeah.
band, and two, stay in the moment. Guys will start wandering, and as soon as they wander, they'll lose it. But when should I evaluate for a venous leak, and is there a workup for that, or what does
Yeah.
that
So if you have
change?
somebody that can obtain an erection, this is somebody that's like, listen, I have no problem getting one, right? Nocturnal erections are fine, T's dialed in, low comorbid factors, right? And you're like, there really shouldn't be any reason why you can't maintain an erection, right? Psychologically, they're somewhat locked in. They're not wandering too much during intercourse. They like their partner, because that obviously is a factor there too. The attraction fades, and if all of those criteria are met, and we have failure of phosphodiesterase inhibitors, then I would consider venous leak at that point. And then I actually have a venous leak specific device in my office that I recommend people use. It causes occlusion of the dorsal vein, and it works pretty good. But you could also use any type of ring constriction device to kind of help maintain it. So those procedures we were just talking about also help with that procedures with venous leak as well. So
Okay, cool. Yeah, I just know that's another thing that struggles and I didn't think about getting specific. I mean, I've just had them do, a constriction device, fancy medical way of saying cock ring,
sure.
and but I didn't realize the specific, spots could help occlude even better.
Yeah, so
Um,
the device that we use, actually, it's called the Xiala device. It's basically a penis ring, okay? And it
yeah,
goes around, but it has like, I don't have one here, or I can show you. I have them at the office. But basically, it's a ring, but what it does is it goes around, but then it has like a tail. And the tail goes actually between your legs and like buttons, like there's a Velcro thing that goes to like the small of your back and it like Velcros to it. And what it does is it pulls down,
that
okay,
is wild.
on the top
Okay,
because your dorsal veins are right at the top. So it basically pulls down and in to help occlude those dorsal veins. So,
that's pretty awesome. I did not know it was that in depth, honestly.
yep.
That's cool.
So yeah, you can get the devices online. I'll give Nigel a free plug here. It's Xiala.com. It's
Nice, nice,
Xialla.com.
cool.
So nice guy. So it's his company.
I had some other just kind of boner questions, but I've already kept you for 50 minutes. So let's
You're good.
let's kind of dive into the prostate portion of it because I do want to hit some portions of this. And I'm going to
Sure.
just start with the age-old question, does testosterone cause prostate cancer?
Of course it does. I'm just kidding. No, it doesn't cause prostate cancer. That was, that came from Hodges and Huggins' study back in, what was it, 35, I want to say, where
Yeah,
they
40s or
yeah, it was
late
like three
30s. Yeah.
patients in the cohort. They gave guys with metastatic cancer testosterone, and it made it worse. Shocker, And I think that what that did do was it established a correlation between testosterone and prostate cancer, but it didn't establish sort of like a boundary of what that really meant. So I think it kind of got misinterpreted as to what it really was, and so that's sort of where the myth that testosterone causes prostate cancer sort of kind of bred out of that and just got perpetuated for years. And it doesn't. We've known that it doesn't, and even before Morgenthaler did his research, we knew it didn't. But nevertheless, like that, stigmas die hard. I'll put it that way. Just like, testosterone causes, heart attacks, right? Where they had a bunch of studies come out in the 90s because they were trying to look at, getting it out of sports. And They had the Anabolic Control Act of 1990, so you had these studies come out. But lo and behold, this study wasn't just testosterone. It was testosterone plus X, Y, and Z, and it causes heart attacks. And
Exactly.
It's like, well, if you're going to just take a guy that's abusing androgens and say he's going to have a heart attack, I'm pretty sure we all know that it does that. But if you're going to take testosterone replacement therapy and lump them in together, I think we need to completely restructure that study and do it. And we certainly have some of that data now. But that's sort of where that myth came from. And we'll move it forward. Saturation model, Abe Morgenthaler in the 2000s basically said that anything, kind of 250 nanograms per deciliter or greater of testosterone yields no more effect on basically growth of cancer. That's sort of like we hit that saturation mark of the androgen receptor on the prostate. And it doesn't matter if you're, testosterone's 250 or it's 1,000, right? We've hit that saturation mark, and the growth will be continuous on a sort of linear plane, straightforward, based on that 250, which is why androgen deprivation therapy, or ADT, basically castrating males, getting them below 250, getting them technically below 50 nanograms per deciliter, is sort of the gold standard therapy, because it puts us below that threshold. And below that threshold, it dramatically slows growth of prostate cancer. So that's why that became a therapy. But we shouldn't shy away from testosterone being, negative as causing cancer or really perpetuating cancer in any way. It will only do it up to a certain point. I think there's a little bit more that can probably go into the saturation model if we could look at it in a couple different lights. I sort of have my own questions that weren't answered, such as like free testosterone instead of total, because we do know that, sex hormone binding globulin plays a pretty large role as to what the total is. So is it a stagnant, we could say 250, but if somebody's got an SHBG of 80, right?
Yeah.
Versus somebody that has an SHBG of like, let's say 10, there's a stark difference in free T levels between those two people. So I think we need to kind of look at it in that light, and that obviously wasn't provided, but nevertheless have some of that framework there. So no, it doesn't cause prostate cancer. It can exacerbate the growth to a point of cancer that is there, notably if the cancer is metastatic. So that's really whenever it would come into play. If you have somebody with osseous metastasis, like it's in the bone, which is very common for prostate cancer to travel to the bone, that person would probably not like you very much if you give them testosterone, because it's going to exacerbate that, and it's going to be painful for them, right? So that's they're going to get a lot of bone pain from that because of that cancer being in the bone. So
Yeah, unfortunately, found like the ER, you just see so many things, and like I found a couple prostate cancer with Mets because of low back pain with an elevated alk phos, and
yeah, like 300.
yeah, and it's like I'm gonna scan this guy, and he's gonna have Mets, and it's gonna suck. And I did that several times, and I found a couple that way. But so like we screen everybody still with the PSA. Anybody that comes in, we get it one at baseline, and then after that I defer to just basic PSA screening guidelines after that. But can I get you to just kind of dive a little bit further? So let's say a guy does have a PSA of just say 5, and you can kind of somewhat expand the workup with a free and a total PSA. Does that do anything in helping detect prostate cancer or rule out prostate cancer?
None of these will rule out prostate cancer from a PSA standpoint. So if you look at PSA, what it is, prostate-specific antigen, was first used in the 80s, became, mainstream in the 90s, which ultimately led to overdiagnosis of suspected prostate cancer, which led to too many biopsies. People were not getting screened, which eventually led into increased metastatic cancer, which eventually led back into, shit, we should probably start doing this again. So that's sort of the PSA timeframe. I did in my master's program at Penn State, I did my thesis project on the PSA. So if there's a topic that I know a lot about, it's definitely this. So your total PSA is going to basically, they want it between 0 and 4. That does not mean that somebody that has a PSA under 4 does not have cancer. That doesn't mean that somebody that has a PSA over 4 has cancer. It's just sort of a de facto in terms, if we're looking at sort of a spread It's the probability of cancer under 4 is a lot lower than the probability of it being 4 or greater. So which is why we kind of have those ranges. Okay. So take that for what you will. And I've had patients with PSAs as high as 15 not have cancer. Biopsy negative. Okay. So it's, it's a tool, but it only takes us so far. So there's some other tests out right now. There's some genomic tests that they can use with the PSA to kind of help. There's what's called a 4K score. There's a couple other tests that are new. I've been out of it long enough now where I kind of don't know where that has headed. But the total is still going to be, routinely done in men 55 to 69 in the absence of risk factors, or sooner if there's a family history or some other risk factor, African American, comorbidities, that type of stuff. You could certainly check one. I don't think it's bad for every man to have like a baseline PSA at like 40, right? Doesn't mean you need it every year at that point, but that was where I was at 40, right? And here's where I am at 45 and maybe at 50, and then start doing it annually at 55. And just trending those values. That's really what it is. It's not a test that you're going to use one value to sort of go off of. It's a test of trends and really what's changing over time. And that's PSA velocity, which I'll touch on here in just a second. But the next question was about free PSA. Free PSA is really only valid for a PSA between 4 and 10-ish. And the higher percent, the better we are. So if I have somebody that, say, has a PSA of, let's say, like you said, 5, and his free percent's like 23, that's good. His probability of cancer is probably pretty low, okay? Versus if his free PSA was like 10, that's not good. When we start getting down to like low or single digits, I'm like, oh, great, here we go. It doesn't mean that he has cancer. None of these are diagnostic for that, okay? But the probability that something's there goes up, okay? Velocity. This is how quickly my PSA changes over time. And this is really good. If you have somebody that has, I have a guy in my clinic right now, wonderful man, been with me for 2 years. PSA is 1.7, 1.9, 1.8, 2, like it's in that range, right? That's his bebop range. Comes back in January this year, his PSA is 3.3. I didn't bat an eyelash, right? He's around 2, it came back at 3.3. Obviously, things can make it go up, bike riding, ejaculation, long flight, out in the yard, riding a snowblower around, you name it. Tractor can make it go up. So I was like, okay, I knew we were going to see him back in 3 months anyway. I was just going to repeat it. So I repeated the test. I didn't get it free because I wasn't really planning on it being up again. And now it's at 6.5, right? So now my velocity over 6 months is from 2 to 6.5. That's a pretty rapid velocity with a midpoint in between. So now I have acceleration in that pattern. This tells me that I need to explore this more. It sucks because this guy's awesome. All our patients are awesome. And I don't want to be the bearer of bad news, but this is also the reality of where we're at. And so I kind of met him in the middle. I said, hey, here's what we're going to do. No sex. Let's eliminate all variables and let's just repeat it. So we just repeated his test. We did it yesterday. I'll talk to him again on Thursday. And we'll see where it is. And my hope is that it came back down. But, we'll see. If it stays elevated, he'll need to get an MRI, which I'm sure we'll talk about here in a little bit. But that's a fairly new thing. I offered a digital rectal exam just to check. We are probably going to do that on Thursday, depending on what the PSA is. Because I was like, I don't want to do it before I get your PSA, just in case it could throw it off. I didn't want to, even though chances of that are pretty low, I was like, listen, we'll do it on Thursday when we see you next week. So he was good with that. But that's velocity, right? We go up in a trending pattern, that should raise some eyebrows, okay? Even if we're still within normal range. If you have a baseline PSA that's like, let's say 0.5, which is a very low value, and that low value goes from like 0.5 to like 2 to like 3.5, I would investigate that at that point in time. Because even though it's in the normal range, historically they weren't there. They were here, right? Mm-hmm. And we have deviated from that baseline. And while it does go up as you age, it shouldn't go from like 0.5 to like, for, the past 3 years to three and a half in 6 months. That's, with a midpoint in between. That's a little concerning. So I would investigate that even. Okay. So that's sort of PSA total, PSA free. PSA density isn't really a thing. That's just sort of measuring how big the prostate is. You can do that a couple of ways. If somebody has a CAT scan, you need three forms of measurement. So we need, volume essentially, so height, width, and depth, essentially, to do that. Or you can do a rectal exam, and if you're good at them, you can come pretty close to within a few grams of knowing how big that prostate is.
So that's what I was going to, your digital rectal exam is a much more sensitive test than my digital rectal exam. I mean, you can call me out and say that I'm just bad at it, which I am. But that is one of the things. A urologist's finger is a much more sensitive test than what I could do.
Yeah. I mean, I hate to admit it that, I've done thousands of those, but it's doing rectal exams wasn't on career day. So it wasn't like anybody was at that booth. But it's a useful test, and I would say really doing a rectal exam on somebody, I would not do them on people with normal stable PSAs. It's not going to offer you any value at that. It's gonna be normal. So just save them the hassle. But if we have deviation from the normal, that's when I would start doing them. Or if somebody had lower urinary tract symptoms, 100% would do that too, because I want to know how big their prostate's getting, which is obviously correlating with their symptoms. So
the ER, one of the things you don't want to massage prostatitis because it could turn them septic. Is that a myth? Is that a
no, it's real
thing?
Yeah, 100%. Yeah. So acute prostatitis is pretty rare. I've only seen it twice in the 6 years I work, and I did inpatient work too. So I did inpatient and outpatient. So I was in the hospital as well, at least 2 days a week. And acute prostatitis is no joke. They are sick, and they can get sicker quickly. So yes, you don't want to massage it. Doesn't mean that you shouldn't do a rectal exam. It's just, if you feel it, it literally feels like Play-Doh. When you go to push a prostate, if you want to know what it feels like for people watching this, if you make a fist at that bulge where your thumb is and you press on it without it flexing, it's gonna kind of feel like that. That's what a prostate should feel like. Firm, but have a little bit of give. When it's prostatitis, it's literally freaking pull your thumb up and just press on that. It's soft and boggy and it hurts. They're like, it's super tender. So.
Yeah, the ones that I've seen, the prostate biopsies scare me because I've seen 2 septic patients and they got septic fast.
Oh, yeah.
I mean, they had that. One guy, he came in, he's like, I just had chills and they told me just to come to the ER. And at first I was like, it's perfectly fine. And within getting the workup, he, tachycardic went up to like 140.
Wow.
His lactic acid was like at 4 already. And then he popped his fever and was like, man, I'm already getting behind the ball here. Let's just dump the antibiotics and get the cultures and everything. And
heck yeah.
So that day I became a believer on, oh man, you cannot play around.
You know what else goes just as fast? Kidney stones.
What's that? Really?
Septic stones. Oh yeah, dude. Bang.
Yeah.
They go fast.
Because I've seen not thousands. I've seen a lot of kidney stone. My criteria for kidney stone, I could almost tell you, they happen at the kidney stone window is about 3:30 to 4:30 a.m. in the morning. And I'll walk in and, complain of flank pain. I'm like, all right, it's going to be a kidney stone. I'll just order everything before. But I walk in, it's a grown man rolling on the floor. And I'm like, how many kidney stones have you had in the past? And it's because they're terrible. I never really had a bad septic stone. I had a couple that I admitted for probable. I had one that I sent to the OR, one kidney with hydronephrosis. And
yeah, got to get that one fixed. Got to put a stent in.
Yeah, I called the doc, and this was a straight up 2:30 a.m. one, and I could tell he was on his defense trying to talk out of it. And he's just, I can't do it. I have to come in. I'll see you in a second.
Yep. He has to. Yeah, he got one kidney.
Yeah.
He doesn't have to take he was not going to take the stone out. He probably just popped a stent and then went home. And they'll take the stone out in a long time. But you gotta get the kidney unobstructed. So that was it. Yeah. That was the thing. So if a urologist goes to take a kidney stone out, I know we're kind of sidebarring here, but And they go
Yeah.
in with the ureteroscope and they break the plane of the stone when they go in with the wire and yucky drainage comes out. They're not touching that kidney stone. The stent's going in, they're going on antibiotics for a week. They're going to come back a week later and then they're going to take that kidney stone out. So,
Okay.
because if they were to take it out with that, they would 100% get septic.
Yeah. All right, I'll get back on topic. Okay, so now I'm worried, and we're going to get an MRI
Sure.
of the prostate. Can you dive into that a little bit?
So that's actually, when I first started in urology, we had MRI, but it just came out and insurance wasn't paying for it. So it really en masse wasn't being used as a therapy until pretty much the latter half of when I was there. And now it's like gold standard therapy, which it should have always been. It's a really, really, really good diagnostic tool. So at first, we only have what's called a 3T MRI, which is a 3 Tesla magnet MRI. So 3T, Tesla is magnetism is measured in Teslas. And so a standard MRI machine is 1.5 Teslas. A 3T would be double that. So, and the image is a lot clearer. So the more Teslas we have, the better image we can get. Because if you know how an MRI works, it basically just uses one giant big ass electromagnet to pull electrons in a direction and then measures those electron shifts is basically how it works. So an MRI is non-ionizing radiation. It's not a CAT scan. It's not an X-ray. It's electrons. But the image we can get is pretty nice. So we do this. It's called a multi-parametric, which basically just means multi-view, essentially, a view of the prostate. At first, it was, well, we have to use a 3T MRI. But now it got pretty good where people were able to look at it through 1.5 standard. By the time I had left, we were just doing 1.5T prostate MRIs because education with the urologist or the radiologists they had all kind of gotten on board and we're doing that. So, but prior to that, we didn't have that as an option. So we just had to go straight to biopsy. So biopsy was which I do want to talk about first because it's going to lead into this.
Okay, yeah.
So biopsy actually is done now. We still do it. It's called a TRUS biopsy, TRUS, transrectal ultrasound biopsy, of which we take 12 cores of your prostate. So if your prostate's, kind of shaped like this and we kind of cut it down the middle, we do 2 on the left, upper, mid, lower, and 2 on the right, upper, mid, lower. Okay, and that's a 12 core biopsy. We've done as low as 6 and upwards of 30.
Ooh.
So yeah, at one point in time, there was a 30 core biopsy, which is insane. I mean, you're basically like, surprised you have any prostate left.
Yeah, just coring the whole bad boy out.
Yeah, yep. They did that one in the OR. I've never seen one done in the 12 core. We just do in the outpatient, in the office. So we just numb it up, and a lot of guys don't complain too much. And we treat them with antibiotics pre and post. So our risk of sepsis is low. Can still happen, but low. Okay. So anyway, you have an MRI. You have this going up. I do want to preface before you even make the decision to have that MRI. Let's say I have a guy and he has a PSA of like 8, okay? And I do a rectal exam on him. And he's got some asymmetry with a really firm nodule, let's say on the right. I'm probably not going to send him for an MRI because the likelihood of cancer for him is extremely high. So
Gotcha.
I'm just going to send him straight for a biopsy. I'm not going to, pass go and collect $200. We're just going to go straight to the source. Because the MRI is basically your decision to biopsy or not. Okay? And if I'm feeling disease, we need a biopsy. So I don't need an MRI. The only caveat there is, and this is why I want to talk about biopsy, is if you get an MRI, you can then have what's called a fusion biopsy. Okay?
Okay.
And a fusion biopsy basically takes your MRI imaging, fuses it with an ultrasound, makes a real-time 3D model of your prostate. And if there was an area in the prostate needing biopsy, area of suspicion, which I'll talk about in a second, then they can actually line the probe up directly to that area, triangulate it, basically take the prostate, flip it this way, flip it this way, flip it this way, line it up directly where it needs to go, bang, get that exact spot. So it's a very focused biopsy. And you can get exactly what you need, especially with multi-parametric lesions. So if you've got, or multifocal lesions, sorry, if you've got one on the right and one on the left, we can get that exact spot and get that exact spot. And then I know exactly what that area is.
Is this something IR does, or is this what the urologist does?
IR does that.
Okay, cool.
Yep. So IR does that. Some urologists can do it, so it's not like it's beyond their scope. It's just generally IR has everything already set to do it. But there are some urology
IR
places
is
that'll do
getting
it.
cooler and cooler.
Oh yeah.
They can do all.
Oh yeah. So that was actually I worked with IR pretty regularly because of some of the other stuff I'm sure we'll talk about. But anyway, you get an MRI if there's no disease felt on exam and you have a PSA. So we're kind of on the fence. We don't know. And we get a 1.5 and we get what's called a PI-RADS score. PI-RADS is basically it's a 1 to 5 score. And it's going to basically tell us, should we get a biopsy or should we not? 1s and 2s don't need a biopsy, clinically insignificant. 3 is your fence. 3 is, you're not supposed to get that, but sometimes they still give it to you. So
Yeah,
they don't make it easier. If I had a 3 with somebody with a PSA that was high, I would just tell them to get the biopsy. If it was my PSA's 5 and I have a PI-RADS at 3, I'd probably let's just watch your PSA. Let's just watch it longer and see what happens. We have up to a year before we can use that MRI for up to a year. So if our PSA deviates in 6 months, then we'll just get the biopsy at that time. And a lot of people are cool. I'm good with that. 4s and 5s are 100% biopsy every time. Okay, it doesn't mean that they have cancer. Okay, again, we haven't diagnosed anything at this point, right? For all intents and purposes, up to this point, no cancer. The only definitive tool for cancer is tissue biopsy. That's the only way you can tell somebody has cancer. So that's what the fusion biopsy is. That's what the transrectal ultrasound biopsy is. That is the only way we can definitively say, hey, this person has cancer. Does that mean if I have a patient that has a PSA of 3,000 and they have a scan that says they have metastasis, that they don't have prostate cancer? According to Assurance, they'll tell you that they don't until you get a tissue biopsy.
Oh my God.
But I mean, that one's pretty easy to figure out, but that's the shit we had to deal with. So
Ludicrous.
yeah, it literally is ludicrous. So, but anyway, you get the PI-RADS score, and then you determine if there's a biopsy. So then they can go have the fusion biopsy, and you can still even do a transrectal ultrasound biopsy even after an MRI too. It's not a requirement to get the fusion biopsy. I'm sure somebody's insurance probably has to play the game with that one. The fusion's a lot more comfortable and because it puts you to sleep for, whereas the transrectal ultrasound is just done in the office. So,
Gotcha.
but the means to the end is obviously getting tissue. So, and they'll core typically 12 cores. Even on a fusion, they'll take other prostate pieces as well. Okay, that'll get sent to Path, and then Path will give us our pathology report. Right, we'll get that back, and I'm sure this is going to lead into our next thing, which is Gleason scores.
Yep.
So Gleason score is actually the old scoring oral grading for prostate cancer. We actually the OGs still use a Gleason score. The more modern is actually what's called a grade group score. So grade group is you have grade group 1 through 5. And basically they just correlate with Gleason scores is essentially what it is. So for those listening, Gleason scores are 2 numbers. They start at 3 and they end at 5. And basically when pathology is looking at this tissue sample under microscope and there's cancer cells present, they will basically look at the features that make it more aggressive. And the more aggressive that cancer is, the higher the score is on that first number. And basically there's usually more than one type of cell present, unless there's just one present. So if there's multi-cells present, there's usually 2 different kind of gradings of cancer. There's a dominant and a non-dominant one. And so because of that, we can have multiple different variations of Gleason scores. So the lowest you can get is a 3, okay? Which would be a 3 plus 3 equals 6. So we have the 2 numbers, we add them together, and we get a 6. So Gleason score of a 6, 3 plus 3, 6 is the lowest one. And we don't even do anything for a Gleason 6, especially low core burden. So on that biopsy, it'll tell us, hey, that piece of tissue that we had, only 50% of it was prostate cancer. The other 50% was just benign tissue. Or, hey, it was only 10%. And it was only in 1 core. We took 12 of them, and only 1 of them, and it only was in 10%. So we know that cancer is in a really small portion of the prostate. And if it's a Gleason 6 and it's in 10% of your prostate, guess what? We call that very low risk prostate cancer. We wouldn't do anything for it. We just watch your PSA. Okay? No intervention, no nothing. take testosterone, do whatever you want, right? You got cancer, it's there, but you don't have to do anything about it, okay? At least not yet. There should still be an exit strategy, and you guys should talk about that. But at that moment, just observe, okay? We call that active surveillance, and that's kind of how that would work out. Then you have more aggressive ones. You have 3 plus 4 equals 7, but you also have a 4 plus 3 equals 7, right? Because we have 2 scores. The 3 plus 4 is called favorable intermediate risk prostate cancer. The 4 plus 3 is called unfavorable intermediate prostate cancer.
Okay.
I don't that they call it that because it looks like if you tell somebody that one's favorable and one's unfavorable, it sounds like they're going to die from the unfavorable. Like you got you got prostate cancer and it's terrible, you know, and you're like, what do you mean unfavorable? Obviously, it's not as great, and it is still an intermediate risk. But again, it comes down to how many cores that you have, what's the burden that's there. You know, there's several things to take into consideration. And just because something is unfavorable intermediate risk doesn't necessarily pose any more risk than of favorable, in my opinion. It does change, you said, on the burden of your cores and how much is there, whether or not we have to stage after biopsy. And that would be a PET scan, or in this case, a PSMA PET scan, to kind of determine is there mets. And that's purely determined because there's some guidelines that are there. If you have unfavorable risk, greater than 50% core burden, should probably stage. Okay.
Gotcha.
Then you have your 8, or your 4 plus 4 is 8. Anything 8 or greater is called high risk. Okay. So it can be a 5 plus 4, 9, or 4 plus 5, 9, or a 5, 5, 10. They're all high risk. And those are, you know, we don't mess around with those. Those are typical, depending on the core burden. If it's, you know, 50% or greater, we're going to be talking about probably prostatectomy at that point. We're going to throw out some of the other lower modalities and kind of bring in the big guns to eradicate that. Those are 100% staging patients. They need staged immediately. And for those listening, staging is basically determining, do we have metastatic prostate cancer? Is the cat out of the bag? And if, you know, they have a negative stage, we can then, you know, give a TNM, you know, T1, T2. I won't bore people with that, but there's basically like tumor classification. Tumor nodes metastasis is essentially what it is. Okay. And you can kind of get that based off of your staging once that's done. So that's Gleason scores. So grade grouping, I know I mentioned that. Grade grouping is, grade group 1 is a Gleason 6, right? Grade group 2 is actually Gleason 7. Grade group 3 is Gleason 8. Grade group 4 is Gleason 9. And grade group 5 is Gleason 10. That's kind of how it works.
I just got bored of the old names.
Yeah, I still the Gleason score. I think it's so important to know what the dominant path is and kind of how we're going to tackle it. But yeah, they just tried to make it more simplified. I don't know if it's being used more now than what it was. We just use the old Gleason score. It's easy to understand. It makes a lot of sense. So, but yeah, so now you've gotten up to that point in terms of, you know, biopsy, staging. Now it'd be, what do you do about it, right? Well, you're going to be classified into two things here. You're going to be non-metastatic or metastatic. And if you're in the metastatic camp, we unfortunately are not in the curable situation anymore. We are not in a surgical or operative situation anymore either. We are in a managed situation. So nobody that has metastatic cancer is going to have surgery or radiation or anything. They're probably going to go on androgen deprivation therapy with androgen receptor blockers, enzalutamide or darolutamide, which is becoming pretty much the gold standard therapy, and see how they do. And if that fails, you know, radium-223, I think there's a couple other therapies out there that I'm not 100% clear on, just because it's not. The last is docetaxel, which is chemotherapy. That's like at the very, very end. So almost nobody makes it that far to go that route. So, right. But that's going to be for metastatic cancer. For non-metastatic cancer, like we call that localized disease, we're going to be looking at some type of curative intervention. A lot of this is going to be driven on your Gleason score, and it's going to be driven on your core burden. It's also going to be driven on, you know, what your facility has as options and how educated you are as a person, and how cool your doctor is. So, I mean, really, it does come to that. So I was the only provider in my practice that utilized all modalities for prostate cancer. If you saw a surgeon, one of our docs, they're 100% probably going to want to do surgery. And if they can't do surgery, they're going to tell you to get radiation. Okay. External beam, which is pretty good. Proton beam is another form of radiation. But radical retropubic prostatectomy or robotic prostatectomy is going to be the gold standard for curative modalities for high burden, intermediate to high risk disease. It's still number one for curative modality. For people that cannot have surgery because they're too fat or, because the other thing is a surgeon's not going to cut into somebody who can't heal. Right?
Oh, yeah, for sure.
Because, even though we can do the surgery, if I can do it, but if it's just going to be nothing but complication, why do the surgery? So if somebody's, grossly overweight, and when we're doing that, if you're doing an open radical retropubic prostatectomy, you're basically going to be cut from underneath your belly button, basically all the way down to your symphysis pubis. And you're going to have an incision there. And if you're really overweight, that incision is not going to heal. And it's just going to be nothing but problems, essentially. So they'll be very selective on who they did surgery on, depending on body habitus and comorbid status. So they would do pretty much everybody, but there were some people that they refused because they're like, won't heal, too big. If that's the case, then we're going to be looking at external beam radiotherapy, or XRT, which has come a long way. And honestly, before I left urology, there was a report done on that versus proton beam, which is another form of radiotherapy. Proton beam was touted in the early 2000s as being, this miracle because it's super tight beams of radiation that can zap in and it just pow, pow, pow. And the nice thing is it can go a certain depth and they can really control it. And it was really expensive. So proton beam centers, when they first started, there was only 6, and now there's 100. So all these proton beam centers popped up. Here's the funny part. Just regular old, what we call XRT, got just as good as proton beam, and it's way cheaper. So they built all these proton beam centers, but nobody's using them for prostate cancer because it's so expensive, and the outcomes are almost identical now. So they're just like, get regular radiotherapy, okay? So that's external beam. You would go in for anywhere between 20 and 30 sessions of radiation where they would just shoot the prostate with radiation. Obviously, there's some complications with that. Radiation cystitis, radiation proctitis, which is basically it fries the bladder or the rectum too. There is a procedure you can get. It's called the space OAR, space OR. It's basically a hydrogel that pulls the rectum or pulls the bowel up off the rectum and creates separation so it doesn't scorch that area too, and can really decrease the issues with radiotherapy. Generally worked pretty well. Again, depends on body habitus, depends on severity of the disease. There's also what's called brachytherapy, where they take radioactive seeds and stick them into the prostate, and that actually kills the cancer, and they just stay in there. So they don't take them out. They just pop them in there and kills the cancer. Works great. It was kind of a big therapy back, I'd say about 20 years ago. Was used a lot more extensively, but it's not used as much anymore. I don't know why. I don't have a good explanation for that.
For all these new ones, I mean, the biggest, scariest thing in prostate cancer treatment is for permanent impotence afterwards.
So
are they
all
getting
of the,
better and better to
they,
prevent
they
that?
are. So all of the methods I mentioned so far, in terms of what they are, do carry the risk of erectile dysfunction post. Okay, all of them. There is not one therapy that is free and clear from the risk of erectile dysfunction, but there are some that have less risk than others. Okay, but they all carry that risk. I would say prostatectomy is the highest risk, and radiation is probably up there with it as well. Listen, they have a nerve sparing technique, but if they get in there and there's something attached to the neurovascular bundle, they're going to take it. It's got to go, right? Because if not, it's basically a pathway to metastatic cancer. And, they're not going to, if you're get the disease out of me and I got to, unfortunately lose erections, do you want metastatic cancer? Or do you not want to have erections?
It's a tough call.
It is. And I've had some guys be like, I would rather have metastatic cancer and still be able to get boners. So
Yeah,
I get it. I get it. It can be a significant
sure.
portion of somebody's life. And then we have high frequency ultrasound ablation or a MRI guided high frequency ultrasound ablation. I was the only person that referred to that, and I really liked that. My criteria for that was basically it had to be intermediate risk or lower, and the core burden had to be below a certain amount. I did send one person there that had high risk disease, but his burden was only 10%, and they got it. So we were good. But basically, that procedure, they take a probe, they stick it into your penis, sleep, obviously, and the probe has a head on it. And think of the head of a clock, and it has 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock, and it's probably about yay big, and it goes into the prostate, in the urethra. And a urologist doesn't do this. Interventional radiology does this too. And what they do is they've already done the MRI, so they know where the cancer is. And again, it lines it up. And what they do is they put that probe in there, and then it's, hey, your cancer was between 9 o'clock and 12 o'clock. We're going to light up those areas, and it sends out microwaves essentially, and it just barbecues the prostate, for lack of a better word. And then they make passes, right? And they just make a few passes, and it just toasts everything up to a certain depth, and it just kills that area of the prostate, but it spares the rest. So I really liked that therapy because that one had the least amount of complications.
Nice.
So
Let's kind of talk about, let's say they got prostate cancer treatment and now we're into, hey, they're struggling, low testosterone state. Everybody in the world has told them they can't have testosterone therapy, but what of these guys can, and what are you monitoring if you do bring them on board?
So I take a pretty unique approach to this. So my approach is this. If somebody had an intermediate risk or lower cancer with a curative therapy done, I will start them on testosterone pretty much even right after they've done therapy. Okay.
You have a Gleason score cutoff or?
Yeah, 7 or below. Okay.
Okay.
If it's a high risk cancer and they've had some type of curative intervention, I generally don't want to start them on testosterone for at least a year. I'm not saying we won't do it. I'm saying I want to see what happens, because you can have what's called biochemical recurrence. And biochemical recurrence is my PSA went to 0 after my surgery, but now it's at 0.5. And that means the cancer's back. If they had a prostatectomy, you can do what's called salvage radiotherapy. You can send them to actually have radiation, a full session of radiation done on the prostate bed, and that might take care of it. But it's really the high-risk cancer stuff that I just like to wait a little bit to see, is anything going to happen, right? Because if it's going to happen, and here's the other thing. Let's say if somebody's adamant and you want to give them testosterone and they're cool with the risks and everything, and their PSA does start to come back, it was probably there anyway, right?
Yeah. Fair.
Like it was there already. We're just speeding up the process essentially of it there. But then when that happens, if they had an aggressive cancer, you're going to have to stop the testosterone therapy. Because remember, it's not localized anymore at that point. It's got to be metastasized somewhere. And so we won't know where it's at. So the goal at that point, and this is why it becomes sort of this really difficult conundrum, is because people don't understand. They think, in Morgenthaler's study, it was localized prostate cancer. It was not metastatic cancer. He did give metastasized guys kind of at the very end testosterone, and they lived the same amount of time. But if you've got somebody that's just starting out on that has biochemical recurrence and they're somewhat fairly healthy, I don't necessarily know if we should technically speed up the rate at which that cancer proliferates, if that could potentially lower the years that they might have left. Right. So that's where I kind of draw the line for that. So metastatic cancer is in a different boat than localized cancer. I'll put it that way. And you kind of have to handle each individually a little bit separate. So that's, I think, where it really comes down into sort of expert interpretation and having some skin in the game with that, and knowing, all right, should we do this? Should we not do this? I mean, you theoretically could at any point in time, but instead, if somebody has biochemical recurrence, they get on testosterone, and now all of a sudden, or they didn't, and now all of a sudden it's back, and we know they have cancer. And chances are, let's say they were a Gleason 9, chances are that's Gleason 9 cancer, just somewhere else.
Dang.
Okay. So and we know that cancer is going to grow quickly. So the last thing I want to do is make it grow even faster than what it's going to be there. And granted, up to a point, so it's going to move along. But for now, we're focused on halting any growth, and that's why ADT is brought in. Okay, if that makes sense.
Yeah.
So, but that's sort of the.
Do you know anything about the estradiol for ADT at all?
Yeah, older method. I think they've kind of shied away from estradiol only because it does kind of have some side effects when you're giving it to some guys that have no testosterone. So,
it's supposed to be overall better quality of life, though, just to have some sort of hormones, right? I mean, I could be wrong. I have not done this.
No, I think you're right on that. I just think they shied away because the Lupron is just. I don't know how long it lasts either, because we never did estradiol therapy. I know it's been used. But for example, if we're going to use Lupron, for example, Lupron can keep basically the gonadal axis suppressed for 6 months. So you get one shot for 6 months and it's just crushed. So, but that's the intent.
And those guys are just miserable. So
they're not too happy. They're living, but I wouldn't say they're living. If that makes sense.
Yeah.
So, but, are they staying around because, they want to watch their granddaughter go to prom and all this, yeah. And I think that's more to them than the quality that they're living on a daily basis. So, I mean, I can't imagine walking around with a sub 50 testosterone. I'd be miserable. So, but that's, it's a discussion you can have too,
Yeah, I mean, I'm trying to figure out something to end it on a happier note. What do we circle back to get some positivity to end on?
Yeah, I mean, it's, I would just say this positively wise, if, get the earlier you can move on something abnormal, the better chance you'll have of not having any of these problems.
Yeah,
right?
Fair. I think that's good. I mean, I've kept you for an hour and 40 minutes. So,
Yeah.
I appreciate the intense discussion. I mean, it was awesome. You provided amazing insight.
Sure.
Taught me some things along the way. So I think it'll be good. And so just to kind of wrap up, where can people find you? What are you working on currently?
Yeah, I can be found at virtushealthoptimization.com or the TRT Dad Unscripted podcast. We typically do one episode a week. There's a few weeks where we might not have one in there just because, we still have other things to do. But we do try to do one episode per week. And, I really enjoy that. And you can also find us on Facebook, TikTok, YouTube, and Instagram. I don't post a lot of short form social media like some other people do. I probably should get better at that, but I stick mostly to the podcast stuff. I should probably do more short form stuff to push more of the podcast, but it's cool.
No, yeah. Well, man, I appreciate your time. Thanks for
Yeah,
coming
absolutely.
out.
I appreciate you having me out here.
And knocking out the penis and prostate podcast with me.
Yeah, we could probably do a part 2, and get a little bit more in depth if you wanted to, but,
Yeah, I mean, there was a lot of other erectile dysfunction, even some prostate stuff that I didn't bring up just for time's sake. So
Sure.
I think we could probably knock out.
Yeah, we could do, another one.
Like an hour long.
Sure. I can talk about
But
this
yeah, man,
stuff
thanks
all
for
night
coming
long.
on. Appreciate your time.
Absolutely. Thanks for having me, Mason.